We have genetic counseling and diagnostic genetic testing for ALS, MND, and FTD, outcomes of a modified Delphi Consensus Survey from Ashley Crook.
Thanks so much for the opportunity to present to you today. I'll be presenting on my final PhD project, a modified Delphi Consensus Survey on genetic counselling and diagnostic testing for ALS and FTD. Just some background information. So genetic counselling is a communication process that incorporates the following 4 goals: interpretation, education, counselling and support. And it accompanies genetic testing. As a genetic counsellor myself, I'm an allied health professional trained to provide all 4 components, but we know that many health professionals provide genetic counselling. And in this talk, I'm referring to the genetic counselling provided by all health professionals. I realise I don't need to do a slide on what is ALS, but I did want to highlight the link with FTD. So these are 2 progressive and neurodegenerative adult onset conditions. And although the symptoms of each are quite distinct, we understand they form a continuum of disease, meaning some patients will have overlapping clinical features of the other condition or shared underlying genetics and pathology. We used to think that only around 5 to 10% of cases were familial, meaning that they ran in the family. But recent studies demonstrate that at least 20% of people with ALS or FTD unselected for family history could have likely pathogenic or pathogenic variants, meaning we basically just can't rely on family history alone to know who may carry a heritable form of ALS. So this is one of the reasons why I'm interested in studying genetic counselling for these conditions, is because genetic counselling and testing is emerging in the care of all people with ALS and FTD. And access to genetic counselling is considered a fundamental right of people with ALS. We know that it's currently not yet standard practice in Australia or overseas that it is offered to all, but it certainly may well be in the near future. It also isn't right for everyone. So genetic counselling is required as part of genetic testing to help with informed decision making. And if a pathogenic variant is detected, for patients it could provide them with an explanation for why disease occurred. For relatives, they could access testing to help plan their future. And for a select few, it could provide them with access to clinical trials. And these clinical trials are emerging and have shown some early promise, and this is likely to increase interest in genetic testing. Currently, there are no consistent approaches to how we provide genetic counselling for ALS and FTD, and the amount of counselling required or recommended is unknown. So on this slide is an overall summary of my PhD project, and the 4 studies that I've conducted are highlighted in blue. The end goal was on developing a consensus statement or standard of practice on genetic counselling. So the literature reviews were first, and they really informed where I was going with the final 2 studies and led me to focus on diagnostic testing in particular. Diagnostic testing is the first testing done in the family, usually on someone with MND or FTD, and it's often the time where discussions in the family might begin. The other thing to note in diagnostic testing is that sometimes due to the capacity of the person with ALS or FTD to make consent, or even their preferences, other family members or carers might take a key role in receiving genetic counselling on behalf of that patient. The focus of today's presentation is on my final study, the Delphi study, which was informed by the findings of the previous 3 studies. So for those that are less familiar with a Delphi, it's a method to generate consensus through a multi-round survey of experts, and a modified Delphi starts with a structured survey. The aim was to really determine what the ideal components of genetic counselling for ALS and FTD diagnostic testing were. We recruited people from one of 3 expert groups, health professionals from genetics, from outside of genetics, and our consumer group, which consisted of both patients and relatives, as well as members or people who worked at ALS or FTD associations with patients and families. We recruited purposively individuals I'd come across through my previous PhD research or clinical experience, and through snowball sampling, all participants could also recommend others. Due to ethics requirements, consumers had to be from Australia, but health professionals could be from anywhere around the world. We wanted to ensure that there was a minimum level of experience to ensure that we did have experts in all areas. So we asked everyone to complete an eligibility and demographic survey. And because we included patients and relatives, and because cognitive impairment can be a part of the disease phenotype, We also had some additional measures to ensure informed consent in that survey. So we developed the item and it was informed by my previous PhD research studies, and then it was piloted first with consumers and genetic counsellor researchers. We did descriptive and content analysis, and we considered consensus when there was greater than or equal to 75% agreement or disagreement. We planned to do up to 3 rounds, and each round was open for 3 weeks and closed for 3 weeks for analysis. Really, we wanted to know whether certain items were required as part of diagnostic testing, whether this was different for select groups, whether there were preferences regarding the timing, and also again any suggestions for rephrasing or changing the item. And on the right-hand side of this slide, you can see a screen grab from RedCap, highlighting at the top of the page an item. And then for each item, participants were asked if they agreed the item was important, and they also had the opportunity to add comments. There was also a supporting information document with key definitions and instructions that they could access on each page. Now, if they did agree or strongly agree, to the item, they were asked an additional question about the preferred timing, and they could select multiple options. They could also answer depending on specific groups, like likely sporadic versus likely familial groups, or ALS versus FTD. And then they were asked a separate timing question again. So overall, we ended up with 46 participants from 9 different countries, at least 10 from each of the expert groups. After round 1, we had a really successful completion rate, with all 46 completing the survey in the adequate time frame. We already achieved consensus of 16 of 20 items, but in saying that, there was minimal agreement to when the item should be discussed. And there were also hundreds of free text responses, many of them making suggestions for changes that could be made to the items. So through analysing the data, we decided to remove the timing question and incorporate comments about the timing within the item. We merged 4 items in with others and then ended up presenting 16 updated items in round 2. So with round 2, we still ended up with a solid completion rate, with only 2 participants not completing the survey in the time frame. But what we did achieve was consensus on all of the items presented. And what I mean by that is that for each of the 16 items presented, greater than or equal to 80% agreed or strongly agreed that these items were important for genetic counselling. There were still over 100 free text responses, but very few of them actually made suggestions for changes that could be made. So through analysing round 2, we determined there was high endorsement and not to proceed with the 3rd round. This is just an example slide to show you one of the items that was developed and informed by my previous research. Provide information in oral, visual and written format to facilitate greater understanding of the information provided and have information available to review when needed in the future. So through piloting and feedback in round 1, the item was then updated, as you can see here. So this is the item we presented in round 2. Provide information in a variety of formats during the genetic counselling discussion. This includes a verbal discussion, a written summary, and all the use of visual aids in response to the client's needs. We also defined what a visual aid was, mentioned the minimum requirement that a written summary was required, and highlighted that the client's needs would inform the extent of the information provided. So after round 2, we ended up with greater than 95% agreeing that this was an important aspect of genetic counselling. So that's just one item, but as I said, we ended up with 16, and I'd love to present them all to you today, but of course, limited on time. So here are a summary of the items that we created as part of this process. As they stand, these items might help to inform health professionals providing genetic counselling to know what needs to be discussed or considered. And they could also be considered as standards of genetic counselling practice in ALS and FTD diagnostic testing. This is an area of work that is particularly timely, given demand for genetic testing is likely to increase as more clinical trials become available. So, on to the take-home messages. So, we've identified a core set of principles for the provision of genetic counselling and diagnostic testing in ALS and FTD. Experts believe overall that genetic counselling and testing discussion should be tailored to the client's personal, familial and social circumstances. Now, if you're a clinician watching this, it may seem like a large list to cover and difficult to achieve in an already busy clinic. So in thinking about how this could be implemented into practice, I'm cognizant of the fact that there's varied health systems and resource limitations, even within countries. So a one-size-fits-all approach to integrating genetic counselling in practice is unlikely to work. So managing the competing realities of what's feasible in clinical care with what's best practice is certainly an area of my future research interest. And there are some possible ways that we could address this issue, which I'll mention briefly here and certainly happy to discuss further. So could be the creation of information and support resources to address some of the client's needs without the need for an individual discussion about all aspects. Linking in a clinical genetics team or genetic counsellor in the clinic, or perhaps using models of genetic counselling care that's already in use in other areas, like greater use of telehealth or mainstreaming access to genetic testing with support from a genetic counsellor or clinical genetics team. So just a few ideas there. Just a quick acknowledgement to all study participants, some of whom I hope are listening today, as well as those who helped me get these projects off the ground. I'm certainly happy to have a bit of a chat now, and I'd be more than happy to answer any questions and continue the discussion at another time as well. So please don't hesitate to contact me. Thank you so much.
Thank you.
Thank you, thanks.
We'll see if anyone's putting any questions in the chat. Not yet, but is there anything else you wanted to add in the end there while I look at mine?
I guess it was great to, sorry, I do have my newborn child underneath me, so she's just waking up, which is great timing. I'll just go there. Excuse me a moment. She's been taken away now. Sorry about that, everybody. I was just going to say it was really great to see the focus last night for me, earlier today for everyone else, on genetic counselling and testing. I think it's really an area where we need to focus, and it's going to be more available for patients, and well, hopefully soon. And counselling is certainly the most important side of it. It's certainly not right for everyone.
Right. Yes, it was quite the discussion. It's you know, genetics has come up so frequently recently, it seems, with ALS and with all the new genes they're finding and all the new testing that can be done. And there's so many questions about who should be tested, who should pay for the testing, you know. So yes, it's a very hot topic right now.
Yeah, and yeah, I guess the other side is the differences, both even within countries. I know within Australia, depending on where you are, you would access different counselling and testing. So it's a real need to have a standard of some kind.
Mm-hmm. Now, the work you've done, you've come up with this a plan or this recommendations. Where does it go from there then?
Yeah, I think if we didn't have the COVID pandemic, I think the idea would have been a big face-to-face discussion next to really go through it together with more experts. What I'm planning to do is publish this initially and kind of go from there, getting some additional feedback from different people, and certainly any thoughts or anyone interested in seeing more or hearing more about it, they're welcome to contact me. Ideally, I'd like to see, I guess, this be implemented in some ways into practice, and then from there actually getting some feedback on the you know, once it's rolled out.
Mm-hmm. Right, and then you can actually follow up with people who, did you get this counseling? How did they talk to you? Like kind of a follow-up as well. Yeah,
part of the PhD before doing the Delphi, I did do some qualitative interviews with people with ALS, FTD, and also their relatives who'd experienced counselling and testing. So kind of understanding what was happening currently, but certainly it would be good to know whether, you know, the counselling provided in future, if it is improved, hopefully the experiences are also improved.
Absolutely. Yes. Yes, it's so important. Let's see. Somebody wants to know if that's your baby's first presentation. First conference.
Absolutely. And she's been sleeping this whole time in the lead up. And of course, it just happened, my 5 minutes of actually live presentation. Luckily, I just messaged my partner saying, I think you need to come and get her. So
that's how it always works. That's how it always works.
Yes.
Let's see. I don't see any other questions coming in. So I think you may be able to go hang out
Attend.
with Attend. Attend to the baby now.
Thank you very much, everyone. I really appreciate the time.
Okay, thank you so much.
Cheers.